So we will start with a case. We have a 67-year-old man with a history of stage 4 colon cancer with mets to liver and peritoneum, currently receiving Folfox, who presents with burning pain in his feet for the past 4 weeks that makes walking uncomfortable. What is the best first treatment to try for his pain? Gabapentin, amitriptyline, duloxetine, or methadone? Give you guys 10 seconds, think about an answer. Answer is duloxetine. We'll talk a little bit more about that. We are talking about chemotherapy-induced neuropathy. The diagnosis is relatively straightforward. So you have to have pain after exposure to an agent known to cause neuropathy. So we're typically thinking about platinum-based agents, vinca alkaloids, taxanes, or bortezomib. It, like diabetes, has a symmetric stocking glove distribution, and you have to have neuropathic pain features like burning, tingling, paresthesias, or numbness, and it is a sensory predominant neuropathy. And around 20 to 40% of patients who receive a neurotoxic treatment will at some point in their course develop chemotherapy-induced neuropathy. The pathophysiology distilled down is that the chemotherapy agent goes into the dorsal root ganglion and leads to apoptosis. And because it involves the dorsal root ganglion, this is why we have a sensory predominant neuropathy. There are no clear agents that are known to prevent chemotherapy-induced neuropathy, but the ASCO guidelines do suggest there are some promising treatments that can be tried. Cryotherapy or compression therapy have multiple trials with variable results. This is typically gloves or socks that are cold, and if it's tolerated as very low harm. And then there's 2 randomized trials looking at exercise, which has been shown to improve quality of life in some neuropathy metrics, although not enough robust data for this to be uniformly recommended. In terms of treatment, the ASCO guidelines do recommend duloxetine as a first-line agent, and this is primarily based on 1 trial of over 200 patients who had chronic neuropathy. This was a crossover trial where all patients were started with 30 milligrams daily for a week and then increased to 60 milligrams daily for 4 weeks. The improvement was modest, with an average 1-point drop, and only 60% of patients reported any benefit. But in the subgroup analysis, there are smaller subsets of patients who did have more robust improvement. And I would say anecdotally, this is also what I've seen, is that there are subsets of patients who do have more robust improvement. And you can start seeing the pain benefit within the first week, unlike the depression benefit that we commonly talk about taking a few weeks to notice. And the question is, what if duloxetine does not work? There was a trial that came out after the ASCO guidelines that looked at pregabalin versus duloxetine in just over 80 patients. And they talked about a positive response if they had over 3-point benefit on a Likert scale. And interestingly, over 90% of patients who received pregabalin had a positive response compared to only 40% of patients of duloxetine. So for this trial, pregabalin was actually a superior agent. But interestingly, prior trials with gabapentinoids have not been positive and have been more indeterminate. But I think this is enough data to show that if duloxetine is not effective, it's reasonable to try pregabalin next. So in summary, the diagnosis, you have to have an exposure and then the neuropathy has a stocking glove distribution and needs to have neuropathic features to meet criteria. There are the culprit agents that we talked about. And for treatment, first line, I think it's still reasonable to try duloxetine, and that's 30 milligrams daily for a week, and then increasing to 60 milligrams daily. But I think there's enough data, even though it's not on the ASCO guidelines, that if patients are not benefiting, to rotate to pregabalin as a second line agent. And that's all. Any questions?
Spiker, thanks so much for sharing. I do have a question.
Yeah. So
I think most of us would probably, I didn't know that duloxetine would have been a first line agent for this. I think I would have probably guessed gabapentin. Is there any benefit to gabapentin in this specific form of neuropathy, or do you use it? Or
so there have been trials that have looked at gabapentin. They just have not been as positive. So I think none of this has explained why duloxetine is superior to gabapentin, but I think in the I lean back on the fact that the trials have just not been as positive with gabapentin when they've looked at this, and gabapentin has been studied. I'd have to look at the specific trials, but for me, I just go on the fact that this data supports this as a first-line agent. And honestly, many of these patients have concurrent anxiety or depression. And I find that duloxetine also is better tolerated in many of these patients from a side effect profile. So I think all that makes me feel okay trying duloxetine first. So I don't think it's wrong to do gabapentin, but I think the data does support duloxetine and may eventually support pregabalin as a better agent. It just, from what I've seen, does not support gabapentin as a first-line agent, and for reasons that I don't think anything I read can adequately explain.
I have a question too. A lot of these patients are often on, say, mirtazapine for their theoretical appetite benefit for cancer patients. If somebody's on mirtazapine, I have read that it's maybe not that beneficial. Would you advocate for, and they also have chemo-induced neuropathy, would you advocate for switching that to duloxetine for that benefit instead?
Yeah, maybe on a different fast facts, I can talk about the reasons why mirtazapine is not a good agent for appetite. I would, just because the data does not support mirtazapine being effective for anorexia, cachexia. So I would, yeah. I mean, you would be careful. I totally think that's a fair consideration about not the risk of serotonin syndrome with multiple agents that are serotonergic. So I would, in that instance, rotate from mirtazapine to duloxetine. Mostly because I don't believe mirtazapine is a good agent for appetite.
Thank you, and I would love for you to do a one on that.
Yeah. It would be like the most depressing 5-minute talk on how everything doesn't work for appetite, but it could be useful still. All right, thanks everyone.